Hi, everyone. I'm Deb Flaschenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flaschenberg, and I'm your host of Yoga Birth Babies. And today we're going to talk about optimal fetal positioning and something called the Gilligan's Guide. This is something I'm just learning about, the Gilligan's Guide. Now, definitely not optimal fetal positioning, because if you've been listening to the podcast, you know that is something I'm incredibly passionate about. When baby is better aligned in the body, then birth can flow more efficiently. So to have this conversation about the Gilligan's Guide, I have Ann Gilligan. So let me tell you a little bit about her. She is a labor and delivery nurse of 33 years. She's also a legal nurse consultant, sexual assault nurse examiner, prenatal yoga teacher, proprietor of the Gilligan's Guide. She teaches providers, nurses, doulas, and pregnant folks how to prevent, identify, and rotate a fetus in utero using what she calls the Gilligan's Guide. So Ann talks a lot about, in this conversation, what malposition is, how it affects birth flow. We also talk about why babies are presenting more in an incorrect position, what we call ROT, right occiput transverse, and how to help them get into a more optimal position. And we also talk a lot about inversions. Should you do them when pregnant? So I think you're going to get a lot out of this conversation. I'm so excited for you to hear that. Now, before we jump into my talk with Ann, I just want to give you some updates of what's happening at Prenatal Yoga Center. So we have added to our on-demand library. So if you can't come to our in-person classes, we want to be able to offer the same services to you online. And with the on-demand library, you can do it on your own timing. So you can check that out. We've added a childbirth education course. We've added a newborn care. And so I think if I'm kind of on track here, every workshop that we offer in person, we now have online, including a lot of our online prenatal yoga classes. So check that out at our website, prenatalyogacenter.com. And while you're there, you can sign up for our free downloadable, the 5 simple solutions to the most common pregnancy aches and pains. And of course, these can be done postpartum. And then you just get a little guide for days that you can't make it to class, but you're still feeling some neck pain or some back pain or some hip pain. I offer you a pose or two how to resolve that. And then it also helps you come into our newsletter so you can hear about what's going on, get a little tip each week about how to support your pregnancy and your birth and your early parenthood. And then the last thing I want to talk about is our teacher training. So if you are someone that's deeply interested in supporting the perinatal community, check out our very thorough 85-hour online or in person. You can decide which one's best for you, prenatal yoga teacher training. It is a culmination of my over 20 years as a prenatal yoga teacher, a doula, a childbirth educator, a parent, and that is what my students are studying, and it's a strong passion of mine. So as I mentioned, you can do it in person, you can do it online. And then before we get to the conversation with Ann, I just want to say thank you. Thank you for being part of the community. Thank you for coming to class in person, online, and listening to the podcast. All right, we're going to take a quick break. When we come back, please enjoy my conversation with Ann Gilligan. Hi, Ann. How are you?
I'm great, thank you. How are you, Deborah?
I'm doing so well. I love talking about baby positions and birth. And so I am so excited to pick your brain and just dive into this. So thanks for showing up for this. I really appreciate it.
I'm so excited to share what I know.
Yay. All right. So let's take a moment and I just want to hear a little bit more about you and how you got into birth work.
Well, I have been doing it for a little while. I graduated from nursing school in 1989, so that makes about 33 years. I have kind of established a reputation at this point of being what we call a well-seasoned nurse. I have experienced many things in the OB world. I've been a high-risk labor and delivery risk, low-risk labor and delivery nurse, meaning that I was working in the birth center for a while. I'm also a licensed legal nurse consultant, prenatal yoga trained teacher, a sexual assault nurse examiner, adult, and also an evidence-based birth instructor.
Wow, you got a lot on your resume. So you know this world of birth very, very well. So what I'm excited to talk about is malposition and how that affects babies. So for those that are listening, you probably know that I've had many conversations with Gail Tully. I have done a ton of conversations about this, but my friend Terry Richmond pointed me in the direction of Ann, and this is one of your specialties, Ann. So I guess we should start with an explanation of what malposition is and how it affects birth flow.
So in explaining malposition, I'm going to start with kind of what it is. So presentation means that what is presenting into the pelvic brim first, meaning is it the head, which we call vertex? Is it the bottom, which we could call a frank breech? Position is something different. Position means which part of the fetal occiput, which is actually the back of the fetus's head, in relation to the pregnant person's back. So if that occiput is on the pregnant person's back, that's called left occiput, and vice versa, right occiput if it's on the right of the pregnant person's spinal, the axis of their body. And there's another thing that we like to talk about in relation to malposition and maternal fetal positioning is asynclitism. And what that means is there is a suture that runs down the middle of the fetal head. It's called a sagittal suture. And if that sagittal suture is not in symmetry with the inlet of the pelvis or the outlet of the pelvis, meaning it's off to one side, if it's the horizontal or the transverse diameter of the pelvic bone, that is considered asynclitism. And asynclitism is also considered a malposition. So anything other than a baby, a fetus, being on that left side of the pregnant person's body and not being in alignment with the bony pelvis, that is considered a malposition. So malpositioning, as we'll talk about further on down the road here, contributes to the arrest of labor. As labor progresses, the malposition cannot correct itself the further it gets down in the pelvic. It makes it harder for that baby. It can correct spontaneously through labor. And interestingly enough, the research that we have is about 10 years old now, 9 to 10 years old. And it says that most of these malpositions actually correct in labor. And only 5 to 10% of the infants are born in a malposition. And I believe, anecdotally, looking at all of the pregnant people that I do today is not accurate to today's statistics. So as labor progresses, the malposition of this fetal head or body can't correct. And so therefore it worsens, it gets deeper in the pelvic cavity and possibly goes what we call occiput posterior. That creates a deflexed head or an extended head going back. The fetal head goes back. And that can contribute to things like fetal intolerance or arrest of descent or arrest of dilatation. So the fetus not being in the correct position in utero contributes to many things that will lead to the morbidities and that we'll talk about today. So super important to recognize the malposition early at term and in labor and attempt to correct it so you can prevent those morbidities that happen in our OB world.
So it really slows things down. So basically if baby's malpositioned, and I'm really enjoying this, but just simplifying it for some folks that are listening, if baby's malpositioned, the ear is to the shoulder, the chin is away from the chest, it can really stall labor, which is why we're seeing some very long labors, a lot of Pitocin used to try to get the power instead of necessarily focusing on the position. Is that right?
That's correct. So right. And thank you for bringing it into layperson's term. It's really something that I strive to do since I've I'm constantly talking to medical professionals, so thank you. But yes, it slows things down, which leads to more interventions, which lead to more interventions. Correct. And so that's what we want to. We want to recognize it early, and that's where I strive to place my education when I'm talking to people. Is let's really try to identify it at term and during labor, so we can attempt to correct it. Because truthfully, with our C-section rate the way it is today, these babies are not spontaneously rotating like they did 30 years ago. And, that contributes to like you said, prolonged labors, increase in Pitocin, increase in epidural use, instrumental delivery, and of course the operative delivery rate. So those are the things that I strive to prevent. So, not to worry, because some do spontaneously rotate, but to involve movement and to involve purposeful recognition of it during labor is really important.
And that's where I think having skilled labor and delivery nurses that are able to help out, if they are, I mean, it's so hard. At least where I was a doula, they weren't one-on-one for a room. And then having doulas that are understanding of baby position. My own first child, his head was asynclitic, and I am so lucky I had a team and myself that recognized something was off. And we had to work very hard. It was a very long labor. It's about 42 hours to readjust. And like during the labor, it just took a super long time. And that was something that really sparked my passion to help those prenatally. How can we better align and balance the body so that baby is more likely to descend and rotate without obstacles, without tension causing the head to move. So you and I are so on the same page with this. This is really exciting.
Yeah. And what you said in the beginning was you recognized it. And oftentimes the pregnant person does recognize there's something that isn't right.
Yeah.
And we need to ask more questions and believe in them when they're stating something as such, because that is where the real power is in listening and listening to the client.
Well, I was a doula at that point for 10 years. So I was an Lamaze teacher. So I was like, oh no, I know what this means. Darn, we have to adjust things. But that also brings up, I'm sorry, what were you going to say?
Well, just going back to my history of when I started in 1989, we would occasionally have an occiput posterior baby. And I remember on the unit, we'd all get together as nurses and we'd talk about, what should we do? Like, I know this baby's OP. Well, on my unit today, I still work in a hospital, and on my unit today, 33 years later, this is a common theme. Malpositioning is the new normal. And so we have to recognize that as a medical community and do something about it. And that is the beauty of my training and my historical work, is that I have seen the trend, and the trend is we often have a malpositioned baby on the unit. Up to 1 out of 4 of our patients at a time are having this problem. And so it's really, really important that we're talking about it today.
Well, that's a huge number, 1 out of 4. So this brings me to kind of thinking back to my history when I was attending births. When I was a doula, I didn't actually see a lot of care providers putting a lot of stock in baby's position. In fact, I would often try to ask, and I did feel like sometimes my efforts were dismissed. But what's interesting is I've been studying to become a spinning babies parent educator, which I know is something you have in your background. And what was exciting was I was seeing a lot of L&D nurses at these workshops. So are you seeing, or how are you seeing fetal positioning being more accepted into the medical community?
Yeah, I'm seeing a great interest. I am teaching a lot more. My business is booming. I am having a big interest from everyone, including providers, nurses, doulas. Doulas are a huge client base of mine, and then the pregnant person, and all about empowering and learning prior to going into the labor room. But the interest in particular of Gilligan's Guide is due to its effectiveness. People are riveted by the effectiveness of it, and so I continue to get references such as why I'm talking to you today of people that are using it. I think that a funny story and how I got to talk to my specific group of physicians that I work with about 5 years ago was a client, going close to signing the permit for a cesarean delivery, and the nurse calling me in the room and asking if I would help with positioning, and me doing my guide with her, and then coming back out to my own patient, which was actually on a different part of the labor and delivery unit. And I see the provider running down the hallway to this room where I just was. And I'm like, oh my gosh, what's going on? Well, she was being called for the delivery. She thought she was being called to sign permit papers and that there was something going on with the fetal distress. And in essence, what she was being called for was a quick response to the guide being done and her for delivery. So she came right over to me and she said, what was it that you did in that room? And I said, well, Dr. So-and-so, I've been trying to tell you that this works in order to optimize that fetal position. So we laughed and she said, okay, you need to come to our meeting, our staff meeting next month and do some instruction. And when people see how maternal positioning works right before their eyes, and when clients experience it from their personal labors, that is how things are progressing. And that's why I'm so excited to be making such a difference, because
well, it helps parents. It really does. And it helps everyone. Having gone through a very long first labor, it was really a battle then heading into parenthood for the first time. So if we can help people not have such a long, hard labor and then possibly more interventions or recovering from a surgical birth, then that's what fires me up. So I love the work you're doing. So I guess before we go into the guide, since that's going to help talk about baby position and how the baby has to descend and rotate, can you talk about the cardinal movements a baby will take on its journey through the pelvis?
Yes. And I was just an interesting note. I was speaking to a group of providers and asking them if any of them knew what the cardinal movements of birth was. In essence, I was asking, what is the first cardinal movement of birth? The group couldn't answer that question. And it's something that we're not taught. And I think that it's really important to understand from the pregnant person's perspective up and to the provider how the baby actually moves through the pelvis and the pelvic floor. But what you have to realize is those cardinal movements of birth that I'm going to speak about only occur when the baby's in that optimal position of being on that left side. So anything other than left occiput transverse, left occiput anterior for the baby to enter into the inlet or the brim of the pelvis experiences those 7 cardinal movements of birth. And the first one is engagement. So engagement leads to descent, flexion of the fetal head, internal rotation, extension of the fetal head, external rotation of the shoulders, and then what we call expulsion, which is birth. Some people say that there's 7. Other people, if you look at the journals and the research, might indicate that there's only 4, which are flexion, internal rotation, extension, and external rotation. But what I talk about in my teaching is that what's happening today, Deborah, is that we are not seeing a lot of these infants at term experiencing the first cardinal movement of birth, which is engagement. And engagement helps with that ripening of the cervix. I don't know if I don't know anything about your family or if you have a family, but when you experience that lightening, you remember it forever. You remember the head on the cervix, and that it's almost like you're working together, the baby and the pregnant person, to ripen that cervix and to prepare that pathway for the birth. And then what we know too is that the ripening of the cervix with the head on the cervix, the baby is actually preparing itself for birth and increasing its surfactant to breathe, and it's increasing its metabolism in order to deal with its sugars to prevent hypoglycemia. So there's all these things that actually happen to the infant by having the baby obtain that first cardinal movement of birth. So prior to today, we would have a bunch of what we call prima gravidas, which are first-time moms, come in, and their cervix would already be ripe. So they would be 1 to 2 centimeters, what we call 100% effaced and zero station. And so there, you can just imagine the progress of labor from there, and the fact that their cervix is already ripe compared to what we're seeing today on admission is a thick cervix, closed, maybe 1 centimeter, and then the baby high. So you don't have that pressure on the cervix. So as the baby moves through these cardinal movements of birth, it prepares the baby for actually extrauterine life in so many ways that we don't even understand. But that is the main problem today, is that babies are not attaining the first cardinal movement of birth, which is engagement. The engagement gives us so much more success rate, a higher success rate when you have spontaneous labor that follows, and you have a baby that's more prepared for extrauterine life.
So I'm sure the listeners are hearing that, especially the pregnant ones. They're like, okay, if engagement's not happening, how do I get it to happen? So how would you answer that question?
So there are ways that you can mimic the ways in which maybe, going back to why this is happening, what we as maternal fetal positioning people, the experts, what we think about is okay, how can we prevent this? How can we prevent the disengagement or the higher station babies from occurring at term? Well, we can mimic what actually was happening 30 years ago. And what was happening was people were up and moving around more and giving more opportunities for the fetus to obtain the correct position at term, which will help with spontaneous labor. So what can we do? Well, we can mimic it by, after 30 minutes, set your alarm. If you sit at a desk job, set your alarm for 30 minutes. And after 30 minutes, go ahead and stand up, especially when the baby's moving, and walk around for a minute and a half. Why don't you maybe swim more? Because in the prone position, we extend our arms up and out in a breaststroke. We allow baby to be hanging down in the hammock. So just thinking about creating more opportunities for the fetus to get in that optimal position prior to term. I see my clients at 34 weeks, and optimally, we would love for that baby to be in that optimal position if it's your first baby, by being on that left side at 38 weeks and 39 weeks if it's a subsequent child.
Let's throw prenatal yoga in that list too.
There's prenatal yoga in that list for sure. And that is, I have a guide. It's called Gilligan's Guide 34-Week Brochure. And that's actually being studied right now in Denver. It's now in its 10th month. And what they're seeing, Deborah, is they're seeing people, and I'm seeing it in my own clients, more people are going into spontaneous labor. So it's in a prevention mode. Waiting until labor can be too late sometimes.
Right.
So we need to do more to prevent it. Prenatal yoga, walking more, realizing that when the baby's moving or kicking you in the ribs, the baby's talking to you and saying, I need a little bit more space here. Can you help me? Can you stand up? Can you raise your arms up? Can you lean forward? Can you get in the bath? All these different ways have kind of been put together in this brochure. And so at 34 weeks gestation, these pregnant people are actually doing these things on a daily basis. And we're seeing more of people go into spontaneous labor. So prevention is obviously the best approach.
Oh, I absolutely love this. Okay, we're going to take a quick break. When we come back, and you did answer this a little bit, but I want to talk a little bit more why you think babies are presenting more in the ROT, the right occiput transverse. And then you mentioned a few tools like moving and swimming and prenatal yoga, but let's go a little bit deeper into that. So we're going to take a quick break. We'll be right back.
Spin your passion into a business with Shopify and break sales records with the world's best converting checkout. Let's hear that one more time. The world's best converting checkout. Shopify's legendary checkout makes it easier for customers to shop on your website, across social media, and everywhere in between. Now that's music to your ears. Any way you spin it, you can be a smash hit with Shopify. Start your $1 a month trial today at shopify.com/records. Spin your passion into a business with Shopify and break sales records with the world's best converting checkout. Let's hear that one more time. The world's best converting checkout. Shopify's legendary checkout makes it easier for customers to shop on your website, across social media, and everywhere in between. Now that's music to your ears. Any way you spin it, you can be a smash hit with Shopify. Start your $1 a month trial today at shopify.com/records.
Okay, we're back. So it is interesting that not all babies end up in that LOA or LOT. So why do you think we're seeing more babies presenting ROT?
There's simply less space on the right side. So you have your liver, which is a very dense organ that extends down beyond the right rib cage. So that is one reason. The other reason is we're just giving, as I stated earlier, less opportunity. So the babies on the right get kind of comfortable on the right side. They're actually more asynclitic on the right side due to less space. On the left side, we have more movable organs like your colon and your stomach. And so baby can actually get over there and obtain more of a non-asynclitic position when it's optimally positioned on the left side. Most babies, as you said, you're correct. Most babies that I see in my work on a daily basis are right occiput transverse and asynclitic. They're heading over to one hip or the other. And that, of course, increases discomfort in the pregnant person. It relates to more frustrations and maybe some more inductions of labor because of the discomfort. So we have to realize that the reasons are real why people are requesting to be done with the pregnancy because they're truly uncomfortable. So that is why they're presenting, is just less space. And so we have to recognize that, and then to know that when the babies do obtain that left, it's a safer, more efficient vaginal delivery.
So if they are ROT, how are you encouraging babies to move to the left?
So recognition is most important. So as you stated earlier, doulas, really important. Establishing a great team of somebody you trust, that you have discovered through your questioning prenatally that they will address the position of the baby during labor, really important. Educating yourselves antenatally, but recognition early in your labor is essential because the further you go down the road of an extended time in labor, the more interventions your team will bring on. So how do you do it? Well, I have a guide, and I will tell you specifics about my guide today. Maternal movement, purposeful movement of the pregnant person, and allowing her or him to get out of bed, to have those telemetry monitors available during labor, really important. And I'm going to talk briefly about AROMs. We'll talk about that a little bit more in detail if you want. But avoiding that artificial rupture of membranes in order to allow the fetus to spontaneously rotate in labor. We need to allow that space. It is stated on all of our people that make our policies and procedures, all of our research-based journals such as the Green Journal. They make a statement to say that AROM should not be done if we're not concerned about fetal status, to allow for that fetal rotation to take place. So there's a trend today that's going on, at least in my world, and I hear about it from my clients nationwide, is that AROM is taking place way too early in the labor process.
So just for those, again, you did say it, but just for those who are like, what's that AROM? That's when the waters are artificially broken. So your care provider might say, oh, do you want us to break your water? So that's what that is. So can you jump into your guide, your Gilligan's guide? And also, how does it differ from spinning babies? Because that is pretty popular right now.
Yeah, I'd love to. So, Gail Tully is here in Minneapolis, St. Paul. I have high respect for her. I actually was a spinning babies aware practitioner. I am no longer per my choice, and I can talk about that. Gilligan's Guide is an algorithm. It's a graphic chart, and very easy to follow. I designed it based on my experience and my thousands and thousands of deliveries that I have attended. So what it does, it is assist the pregnant person's body to rotate their unborn fetus into the optimal position for birth. It's very safe. It's very efficient. It's very simple. And safe is my big word. As I stated, I'm a registered nurse with a license. I am a legal nurse consultant. I want everybody to be safe. And that's one of the reasons why I don't throw Gilligan's Guide onto the internet for everybody to do, because I think that it's really important as a nurse to determine if there's any health concerns with my pregnant people. So it's 4 maneuvers. As I stated, I designed the sequence of them. I designed the first 3. The last one is actually one of my mentors, Dr. Carol Phillips. And Dr. Carol Phillips designed the sideline release, which is the last final maneuver. So what I do is I teach people how to prevent the malposition to begin with. So I take them at 34 weeks is the perfect gestation. I show them how to do the homework. I demonstrate things. I talk about the importance of different things after identifying their health history. And then number 2, I teach them how to identify the malposition. So it's really important for the layperson and the doula and the nurses and the providers to be able to identify the malposition. And that is really important to know how to do it from a different perspective. You know, a doula can look at the belly. A doula can put her hands on the belly. She can't diagnose things, or he can't diagnose things, but he can help that pregnant person identify it. So can the support person. So I teach them how to do that. And then I teach even deeper the medical provider way. When you're doing an exam, what are you feeling? When you're observing the pregnant person in labor, what are you seeing from a subjective and objective point of view? So I teach them all of that. And then I show them my actual algorithm, and I teach them how to do those 4 maneuvers. And then I do a follow-up email. I'm always available to the clients for questions or concerns. So it's a deeper dive into maternal positioning. It's from a nurse's perspective, and a nurse's perspective that has a lot of experience in the field. And I'm always thinking about safety. I'm not going to tell somebody to do a puppy pose for 30 minutes, for instance, when I don't know what her blood pressure is. So that's where I'm coming from, Deborah. And I'm not saying things are unsafe in other venues. I'm just saying this is my perspective on maternal positioning. I request that when you do Gilligan's Guide that you're at your place of birth because it works so well. And I also request that you monitor the fetus. And that could mean doptone. It could mean a intermittent monitoring, or it could mean continuous. But I do want that person knowing what the fetus is doing while they're doing my guide.
So this isn't something that people do ahead of time to help prepare to get baby engaged.
Right. That the actual algorithm, thank you for clarifying because it is confusing. The algorithm called Gilligan's Guide is to be done at the place of birth. And that could be home, right? If you have a midwife coming to your home, and it also requires, per my request, that you're monitoring the fetus during the guide. What you can do ahead of time is related to the tools that we'll talk about in your next question, and the four principles that I want you to pay attention to. So there's four things that I would love for.
Let's go right into that.
Great.
Yeah, please
Thank
do.
You. So the four principles, the things you can do at home, and the beautiful thing is your body's already telling you to do these things. So you just kind of need to listen to your body. But the four principles, and you should follow them in this order. So the number one thing you need to do before you do anything in relation to positioning is you need to relax the muscles and ligaments first. So if you talk about what ligaments are, they're dense bundles of parallel collagenous fibers. I love saying that because it's so beautiful. And they're functioning clinically while you're pregnant to stabilize, right? To stabilize that lower uterine segment and keep your baby safe. But if they're cold, they're stiff, right? They're not, they don't have that elasticity that I want to see. So I want you to think about relaxing your lower uterine segment. And what I'm talking about specifically is your broad ligament, uterosacral, round ligament, and then in relation to the pregnant person's body, the psoas, iliopsoas, and your gluteal muscles. So if you think about that,
let's break that down for someone that's like, what are those? All right. So the broad ligament, I kind of think of it like a little scarf holding the uterus from the back to the front. I don't know if it makes sense. Kind of like a wraparound.
It's a fold of the peritoneum. You're correct. And it is kind of this, it's what the uterosacral and round ligament are actually embedded into. So we want to think about just if you take your hands and put them on either side of your lower uterine segment, they're going to wrap around and they're going to be in the front here is how they stabilize the front. You only have support on your uterus on the bottom part of your uterus. The top doesn't have that support. So you want to relax the lower uterine segment is how we regard it in medical terms. And so if you place your hands right on either side, right on top of your, kind of in your groin area, that is the area that I'm referring to. And then the psoas is attached to L1, L5 and wraps around to the inner trochanter. And
a lot of people think of those as the hip flexor. Again, I'm kind of putting in lay terms.
Very good. Hip flexors, but then the gluteal muscles too. So think about those big muscles in your buttock, right? So those are usually tight and they're not working efficiently when we're sitting on average 8 to 10 hours a day. Those aren't working efficiently and they're not firing and they're actually losing their elasticity. So when they're cold or when they're tight or twisted, we need to think about relaxing them. So we want to think about ways to relax the muscles and the ligaments of the lower uterine segment. And you can do this using your psyche. You can use this using your mind. You can use imagery. You can use music. You can use positive encouragement. You can actually use external forces too, such as getting in the tub, directing the shower head directly at the lower uterine segment, putting a warm compress on either side of your broad ligament. So you want to think about that. And what's interesting, Deborah, too, is when we talk about external cephalic versions, which is the rotation from a medical profession of a baby that's breached to a non-breach position, we should be thinking about that too. We should be thinking about my number one principle of let's start thinking about relaxing the lower uterine segment prior to that extreme movement of skillfully bringing that baby to a vertex presentation. Mm-hmm. Because I've done it and it works when you think about that. Bringing that principle of relaxation in. So before you do anything.
I've had some doctors I've worked with actually give an epidural for that. I'm assuming it was the same reason, just to soften everything.
Yeah, but that turns it into an extreme medical.
That was quite a thing. But that was my thinking. I wonder why they were doing that. And I assumed it was just to soften everything.
Yeah, it does relax the uterine. It does relax the lower uterine segment. It does relax the pelvic floor. It relaxes everything from your belly button down. So. Right. But I'm talking about just putting warm compresses on your broad ligament for 10 minutes. You'd be amazed at what that does.
Yeah. One of the things I would pack, since I'm not practicing as doula anymore, but one of my favorite things was a hot water bottle. And I would put that at the lower belly, obviously with like a little cover over it. And then also at the sacrum.
Yes.
I found a lot of people really enjoy that there too.
Yeah, you cannot ignore the sacrum and the ligaments that support the sacrum, the SI joints. I mean, it's really important to relax. So number 2 is you need to create space. So we can talk about all different ways to create space.
Space.
Yes, space. And I'm talking about your space from your pubic symphysis, which is the inlet of your pelvis right at the top, to your xiphoid process, which is the bottom of your sternum, which is right down the middle of your rib cage. So if you think about creating space from your xiphoid process to your pubic symphysis, if you put your finger on your pubic symphysis and put your finger on your xiphoid and you're sitting down, all you need to do is stand up. By standing up, you're going to increase it by 3 to 4 centimeters. And that is why upright positioning, we know per research that decreases the amount of time in first stage and in second stage because you have gravity and more space. So the number 2 thing is creating space. Number 3 thing is now you've got to help this baby tuck its fetal chin. Because so many of these babies are asynclitic and have, as I stated in the beginning, have their fetal chin gone back, especially with an occiput posterior baby. Their heads are extended. So we need to help these babies tuck their chin. And number 4, now you need to actually correct the position. But you need to think about those 4 principles in that order in order to rotate a baby. And so you can create your own Gilligan's Guide, but you really do need to think about those 4 things in that order in order for you to have success.
Right. So I think a lot of people are like, okay, I can warm up the lower belly. That's doable. They can stand up. And then you're talking about chin needs to be into chest. So the smallest part of baby's head is pressing against cervix. And that's where I think some people are like, okay, how do I do that? So can you offer some ideas about that?
So without telling you how to do the guide, because I'm not going to share that with you today, unfortunately, because I want to do that on an individual basis with taking a health history. So if you just think about ways that your hips can move, I was taught by one of my favorite people in the world, one of my friends who's a doula, that it's really important to move like a hula dancer versus a person that's doing the foxtrot, right? You want to be able to lift your hips and lift the right hip and then lift the left hip, because that's going to give momentum for the baby to tuck its chin versus particularly if the baby's in the mid pelvis.
Got it.
So just listening to the body, listening to the movements, allowing that person to get out of bed, and that's going to really help. But I do have a specific way called fetal crown tuck that I teach that actually can help, that will help tuck that fetal chin.
That makes, no, I get it. I totally respect that you want to work one-on-one. And so that also brings me to, you'd mentioned you don't encourage like a butt up child's pose. So, and that is the reason you don't teach inversions. That's because you don't know the medical history of somebody.
So here's how I approach inversions. And this is based on my own health. And, it started 25 years ago when I was diagnosed with, glaucoma. And I have a type of glaucoma for young. Obviously, I was young then, and it's a type of pigment dispersion glaucoma. And I worked with a recognized ophthalmologist, glaucoma specialist. And what was happening was I am a yogi, and I did yoga daily, and I got into the crow poses and the headstands and everything. And what we were seeing, because I see my glaucoma specialist every 6 months, my pressures were going up. And because you check your pressures when you go in for glaucoma, and my pressures were succeedingly with each visit going up higher, and I was requiring a second medication to maintain those. So what we concluded was it was my yoga inversions that were actually increasing my optic pressure. So here I am, a labor and delivery nurse at the same time. So I'm realizing that when you put your head below your heart, you are increasing the intracranial pressure. Okay? So just know that. So now we take today's pregnant person with increased blood pressure unbeknownst to them. And particularly today since COVID, Deborah, we're seeing more preeclampsia than we've ever seen. We don't know the relation yet. So you encourage people to do inversions when you do not know their pressure. And from a safety standpoint, I do not agree with full inversions, and we'll talk about the difference, in a pregnant person unknowingly not knowing what her blood pressure is. I don't think it's safe. I think you need to recommend, you need to talk to your provider about it, and then work into it gradually. So just know that inversions will increase the pressure in the blood vessels of the brain. And it all depends on how far below the head, how far below your heart your head goes. So if you do a down dog, for instance, your head is slightly below your heart, but here's the difference. My trunk is still not above my heart. So I'm in a V shape. Mm-hmm. Right? So then the second question is, how high above the heart are the legs in your trunk? So if you're doing a full crow or a full headstand or shoulder stand, you're creating the most pressure in your intracranial cavity. Mm-hmm. And so you can safely do down dogs. That's considered a mild inversion. And particularly if you've worked your way up to that, because what happens is your blood vessels get used to it. It allows your blood vessels over time to strengthen in order to resist that increased pressure. So it's not like you're training your blood vessels. Mm-hmm. So I'm not going to tell my pregnant people to do full inversions. And I'm actually going to tell them to not do full inversions while pregnant.
I totally agree. We don't teach inversions, and we do down dog. I'm going to say we do down dog, which, say minor inversion. But no, we do not teach full inversions in our prenatal style. I have many reasons, but I hear what you're absolutely saying. So I'm glad to hear when you said that. I'm like, oh, I hope she doesn't include down dog in that. But good.
No, down dog is different. Yeah, I mean, think about your V shape, and you're holding it there for 30 seconds? Yeah. And so you have to realize that gravity has its place, right, in the birth world.
Absolutely.
I mean, there are some times when I do Dr. Carol Phillips open knee chest. She developed that. I do open knee chest because we need to get that baby out of the bony pelvis. But full inversions, Dr. Carol Phillips actually designed that for the OB world. That was not the original intention. I heard this from her because she mentored me. She developed it so you go down and you come up within 3 breaths. And so I've told other people that are teaching maternal positioning that I don't advise it based on my own medical history and my own discussions with my glaucoma specialist. And he showed me all the research. We looked at it together, that it does increase your optic nerve. It does, increase your vitreous humor pressure, which can damage your optic nerve. And it does increase your intracranial pressure. And the reason why we're concerned about pregnant people and intracranial pressure is that you could have a potential seizure if you have preeclampsia. And so we want to avoid that. And so that is why in my heart of hearts, I don't encourage people to do full inversions while pregnant.
No,
so
thank you for explaining.
That's a big explanation, and I apologize for being medical, and I obviously have a big, I'm very passionate about it, but I'm only passionate about it because it's been a concern of mine personally for so many years.
No, I appreciate it too. And again, we don't, at my studio, we do not teach the pregnant person inversions. We don't have a place for that in our practice, but that's, again, my own take on that. So thank you. So we've been talking a lot about fetal positions for a vaginal birth. And I know some people are probably like, why are we so focused on a vaginal birth? And I just want to remind people, it's not that cesareans are bad because they absolutely have an important place in birth. I think they really do. I think they could be overused, which could be a different discussion. But I feel like not all the time are the risks explained about cesarean. So maybe explaining the risks associated with cesarean so those that are listening can understand your passion and my passion about helping people find a more efficient flow for birth for a vaginal birth.
Yeah, you're so right in the fact that I literally have been down on my knees thanking my team. And I can get really emotional because I've seen so much and been involved in so many deliveries that there have been times, Deborah, where I have, put my hands together and thanked them for their skill at delivering these babies quickly and efficiently and actually quite beautifully as they enter into the abdominal wall to get a baby out safely. But what I have seen and what is demonstrated in our research and all over the journals is that we have more than tripled the rate of C-section since I had my first daughter in 1992. We're now at 32% in the United States. The U.S. has one of the highest C-section rates in the world, and it's predicted that by 2030, it's going to be 1 out of 3 people are going to be delivered via C-section in the U.S. And with that, as you stated, comes morbidities and even mortality. And it's grim. It's a grim subject and it's hard to hear, but I do want you to know why I work so hard to empower my people and my OB teams to deliver vaginally, because we do know those risks. I mean, they're well documented. But first I want to tell you the most common reason for C-section, and this is in order of occurrences. Number 1 is labor dystocia. And we know that labor dystocia is directly related to fetal malposition. Number 2 is non-reassuring fetal heart rate tracing. That is something that is not research documented yet, but I really encourage it with my experts in fetal heart rate tracing, is that when a baby is in a malposition, you will see non-reassuring fetal heart rates. And when you fix the baby and get it out of that vagus response, autonomic nervous system response of having its head tilted back, you will have an improvement in the fetal heart rate. So that's number 2 reason for C-sections. Number 3 is a fetal malpresentation, multiple gestation, and then suspected fetal macrosomia. So we're delivering people on the suspicion.
Big baby.
Yeah. We're delivering sections. We're planning the section for a suspected big baby. And there's a really good article on evidence-based birth. I have to plug my Shira, Rebecca Decker, on big babies. So make sure you look at that. But C-sections, just briefly, is associated with an increase in morbidity and mortality than vaginal birth. So that is why I strive. Prevention is my motto. And so I try to prevent it with a vaginal birth. Subsequent uterine rupture is 1. Placenta accreta, which is when the placenta attaches to the uterine wall, particularly the wound or the incision. Hemorrhage rates go up. Hysterectomy, which is when they have to remove your uterus. Maternal death, which is really hard for me to say. Bowel bladder injury, surgical site infection, and venous thromboembolism, which is quite deadly. And then we have to talk about the neonate. So there's decreased breastfeeding rates. And the biggest thing is all of this increase in our C-section rate does not appear to improve neonatal morbidity or mortality. So WHO, which is our World Health Organization, has recommended that the C-section, if you were to take everything into account, we can prevent and decrease it safely to 10 to 15%, which is the goal for 2020 healthy people. That was the goal for 2020, and now they've made a new goal for 2030 to be around 10 to 15% is where we should be.
Got a lot of work to do to get to that.
We do, and a lot of people are working hard.
So again, it's not just for the community listening. It's not that we demonize cesareans, because they really do have a place. I think what we're agreeing, or at least expressing, is that can we reduce the rate of them for those that it's not, I don't want to say medically necessary, but medically indicated? And can we, as Ann was saying, community, labor dystocia, stalled labor, a lot of these things that we're talking about today can improve labor stalling. And so again, I'm just so excited that there are ways for people that are really invested in not having a cesarean, trying to find a more balanced body so baby can be better positioned. So I'm so happy for the work that you're presenting. So thank you.
Thanks for giving me the opportunity. It works. It's something that empowers the pregnant person. In the end, once I finish doing the guide, it is all about looking at them in the eye and telling them, and them knowing, obviously, they feel a difference. They no longer have back labor. They feel maybe some pressure in their pelvis. Telling them what they just did and the power of their body to have completed that circuit and to have done that. Even, sometimes it's when they're very tired and they're just at their wits' end. And they're able to go through that and do it. And it's so empowering to them. And like you said, it's the beginning of their parenthood. I mean, this is something, we have the most important job in the world, and we have to realize it, that those hours that we spend with people in labor are the beginning of their parenthood. And if we can make them feel whole and strong and successful, not that people that have a cesarean section don't feel that. I'm not implying that whatsoever. I am so in awe of people that go through cesarean section. It is another way to birth, but I strive every day to decrease morbidity by attempting to allow the body to do what it's meant to do, and not putting up barriers like the bed and the laying flat position and the not allowed to move because of the fetal monitor. We need to improve that space and allow for their body to do what it was meant to do.
Oh, so beautiful. We're going to take another break. When we come back, now you have years of experience with this. So think about one final tip or piece of advice you'd like to offer new and expectant parents. All right, on our break, see what bubbles to the top of your mind. We'll be right back.
Spin your passion into a business with Shopify and break sales records with the world's best converting checkout. Let's hear that one more time. The world's best converting checkout. Shopify's legendary checkout makes it easier for customers to shop on your website, across social media, and everywhere in between. Now that's music to your ears. Any way you spin it, you can be a smash hit with Shopify. Start your $1 a month trial today at shopify.com/records.
Okay, so what golden nugget do you want to leave us with?
Okay, so I often tell my clients this, and it's the philosophy of my world, and I know it in my heart. I feel it. I see it all the time. The ability of the body to birth. So what I'm telling you is I want you to know your body. I want you to know your baby. I want you to surround yourself with people who listen to you, truly listen to you, support you, and quietly encourage you. And I want you to be the expert. Oftentimes I'm asked, gosh, you just taught me this. How do I approach this in the labor room? Like, I know all this information, and what if they don't believe me? They will believe you. You need to know that you're the expert. Learn all you can about the tools to prevent, to identify, and to correct the malposition baby. And then finally, no worries before 39, 38 weeks. So go about your beautiful pregnancy and the health of your baby and your body. But really, it's not a concern until you get full term at 38, 39 weeks that we want this baby to be in that optimal position of being on the left side.
That's so wonderful. So where can people find your work?
So Gilligan'sGuide.com. I'm on Instagram at Gilligan's Guide. Know that you can reach out to me for anything, for questions regarding a past birth, questions about a future birth. I'm here for you. This is my jam right now. This is what I do. This is what makes me happy, fulfilling, and I'm here for you. And I'm proud of you and however you're approaching your pregnancy.
Thank you so much for offering so much knowledge and so much for people to think about, and also for people to realize that they can very much be a part of this birth experience. They don't just have to watch it unfold. So thank you for giving the power back. So I appreciate it.
I appreciate you so much. And I love that you're teaching yoga to pregnant people. It's very important.
Thank you.
This has been an episode of Yoga Birth Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.
Spin your passion into a business with Shopify and break sales records with the world's best converting checkout. Let's hear that one more time. The world's best converting checkout. Shopify's legendary checkout makes it easier for customers to shop on your website, across social media, and everywhere in between. Now that's music to your ears. Any way you spin it, you can be a smash hit with Shopify. Start your $1 a month trial today at shopify.com/records.